Yeah, just have you got? Has anyone got a microfiber cloth for glasses? Cheers. It's 99:20, so we can always join 2 minutes late. But we've actually got a reason to be late, because it's Indian standard timing, and Indian things always run late. Welcome to Health Careers Live India 2021. We're so excited to welcome you all today to what marks the launch of our first Indian edition. My name is Dr. Rajiv Sethi. I'm a doctor by background and the founder of Health Careers Live. Health Careers Live is an NHS Parliamentary award-winning platform that supports aspiring and current healthcare professionals, and now this marks our first step to supporting health systems globally. We know the challenges that we're facing aren't unique to any specific health system, but are global in nature. And today we're really excited to be joined by speakers from across the UK and India. So, just to get you familiar with what's going on for the rest of the day, our event platform, which you're all on at the moment, or you may well be on YouTube, so that's the alternative stream, which you can watch by searching Health Careers Live on YouTube. You'll be able to view the stream from the day through the panels. And on the platform itself, we've got some really exciting features. So you can click on the networking tab, and that allows you to almost speed network with other delegates. View our exhibition and see all the amazing supporting organisations, including the General Medical Council, Health Education England, and our other partners. And of course, don't forget to make use of the chat, because today is all about exploring this conversation around how we can support the UK and India in tackling the challenges in healthcare, but also around connecting. And we know that you've all joined today on a Saturday because we're all passionate about improving health and supporting each other to be the best for the patients that we serve and overall to improve society. So thank you so much for joining us today. Please feel free to share your thoughts using the hashtag HealthCareersLive. We'll be monitoring the chat on Twitter, Facebook, Instagram, and of course on the event platform itself. Really excited for the rest of the day, and I'll be back with you very shortly.
It's been a brilliant day bringing together so many different organisations, healthcare professionals, students from across the UK and beyond.
It's an amazing opportunity to learn about such a huge range of health careers. We hear a lot about like medicine and dentistry, but we don't often hear as much about the 350 roles within the NHS, and that's something that as a conference we hope to try and challenge, to get people to think beyond the courses that everyone knows about.
There's something for everyone, and it's from like undergraduates for students, all the way up until people who are graduated and are working.
We've got AHPs, we've got aspiring medical students, dental students, nursing students, so everyone's represented here.
It is designed to have something for literally anyone. No matter what you're interested in, we will have a talk that covers it.
This is a brilliant programme that brings together so many different professions within the healthcare community, and it's one that should definitely be on everyone's calendar.
My name is Mark Radford. I'm the Chief Nursing Officer for Health Education England.
I'm Sarah. I'm a neurosurgery trainee currently working in Cambridge.
I'm Adrian James. I'm the President of the Royal College and I'm really delighted to be here.
My name's Abby and I'm the Careers, Information and Quality Lead for the NHS Health Careers team. I hope to be able to get across to you some of the amazing opportunities within the NHS.
We have got podiatrists, occupational therapists, speech and language therapists.
So we're going to talk about good medical practice, we're going to talk about protecting patient safety.
Because of restrictions, because of remote working, because of the lack of face-to-face contact, because we've had to manage patients a different way, we've had to think differently about how we manage this work and how we use technology.
I'm in London, so good to see you. I think we've got Ian here as well, haven't we? Hi Ian.
Hey guys.
We are not the only people who are facing problems, but actually through sharing those problems, we can become the health professionals that are required for the globe and for the NHS in the future.
It's been really interesting hearing all your top tips. I've got my list now. I can pack my bags. I'm going to wear my seatbelt for safety, but I am going to look out the window ahead of me and enjoy the trip.
It's just about us finding the greatness within us and bringing it out and being our best self.
Welcome back to Health Careers Live India. I'm really excited to launch the first session of today, the India-UK Roundtable. We know that health is connected across sectors, and today's panel reflects that. We're really lucky to have high-profile innovators and leaders in their professions join us to talk about the relationship between the UK and India and how we can work together to support each other and the health systems. Joining the roundtable today, we have Dr. Shashank Wikram, the Consul General of India, Dr. Amandeep Singh, President of the Resident Doctors Association at All India Institute of Medical Sciences, New Delhi, Shala Hassan, the Executive Director of the Manchester India Partnership, Tista Chakravarti Gannon, the Head of Outreach at the General Medical Council, Mr. Salvasekar, a Consultant Surgeon, Director of Surgery at the Christie NHS Foundation Trust and the Chair of the British Association of Physicians of Indian Origin, the North West Chapter, and myself, your host, and I'll be helping moderate the session. I'm a doctor based in Manchester and also work closely with the Global Health Department at Health Education England and as a clinical entrepreneur fellow at NHS England. And just to provide some backdrop to today's conversation, Health Careers Live is all about bringing together people from across different backgrounds to support the health workforce. This began in 2017 as a National Health Careers Conference in Manchester, supporting aspiring healthcare professionals and really providing opportunity across the field to ensure people can pursue the careers of their choice. And ultimately contribute to an improved health system. And today is very much the next chapter of that journey, seeing how we can work together across countries. And I'm really excited that everyone's been able to make today and give up their valuable time this Saturday to help us achieve that goal. So, without further ado, if I'd like to ask everyone to introduce themselves, if we can start with Shashank.
Hi, thank you so much. And well, I'm Dr. Shashank Wikram, and I am the Consul General of India for Midlands and North of England. And healthcare sector, I mean, we are only supposed to introduce ourselves, so that is the introduction. And I can only add the line to it is that healthcare sector is one of the priority sectors between India and UK. And we look forward to its further strengthening because we understand that there is a lot of complementarities between the two healthcare systems. And as we go forward, I would like to dwell on it further.
Really good to have you join, particularly, I think, as a medic by background, I think, you're bringing in such unique insights in this space. So thank you for that, Shashank. Tista.
Hello, hi. First of all, thank you so much for having me on the panel. It's really good to be here. So by way of brief background, I've been working in healthcare for 25 years now. My non-GMC work is with survivors of abuse. I still do that work, and it was through that many years ago I became interested in systems and what can go wrong with for patients when systems don't collaborate well together. And that got me interested in regulation. So just over 10 years ago, I joined the GMC, the General Medical Council, and was asked to set up a support service for doctors on the ground. And that's what I now head up with colleagues, the outreach service. And as part of that, I also head up our induction programme for internationally qualified medical graduates. So that's why I'm here today.
Amazing. And Tista's been here from the very beginning in 2017 when we first launched this conference. So we're so thankful for your continued support, and particularly today for international medical graduates looking to, to start work in the NHS. So thank you so much, Tista. Moving on to Amandeep, and Amandeep's joining us all the way from New Delhi in India.
So a very good afternoon. I'm Dr. Amandeep Singh, and I'm a senior resident doctor in Department of Medicine and Infectious Diseases in All India Institute of Medical Sciences, New Delhi. And along with this, I am the current president of Resident Doctors Association. It's a group of 2,500 resident doctors of various specialities who come across India and other countries to study in All India Institute. We do a lot of activities, whether it is related to research, and along with that, in the current time of COVID, we have XLR in online education through various modes, and telemedicine. As we see that there is India has a large population, and we see large number of patients. And during the COVID pandemic, when lockdown was there, we were there, and the association was very much helpful for the patients. So I thank and I'm glad to be a part of this. And being I'm still a student, but I'm thinking that I will gain a lot from this session. Thank you so much.
Great, we're so lucky to have you, and thank you for making time to join us today, Amandeep. And just to let everyone know, I'm not being rude when I stare down. I have my iPad with all the exciting social media buzz and the chats from the conference. So I will be occasionally looking down. And if we can move on to Shella.
Good morning, everyone in the UK, and good afternoon to everyone in India. I am Shella Hassan, and I have recently taken over as the Executive Director for the Manchester India Partnership. Not a doctor like the rest of you. I've built a career on the UK-India economic bilateral relationship for the last 14 years, starting with the British Deputy High Commission in Calcutta, and then moving on to heading the Confederation of British Industry for the last 9 years in Delhi. I started my career as a business journalist with Business Standard newspaper in India. So UK-India economic, the whole dialogue is good enough to build a career on, and I guess I'm one of those people who has done that. And healthcare is one of the focus areas, not only of UK, between UK and India, but also between the Greater Manchester region and India. Especially digital health going forward, and lessons learned during the pandemic. Very much, and people ask, why India and why Manchester? First of all, India is going to be the fastest growing economy for this current financial year and the next. So, all the more reason to engage with India. And then, the challenges that we face here as well as in India are very similar, especially when dealing with the pandemic and other issues. So I think I'll stop here. I think perhaps catch up when the discussion is on. Thank you.
It's great to have you with us, Shella. And I don't think, arguably as a doctor by background, I don't always think that just because you're a doctor or clinician by background, that's the only qualified opinion. And we're really grateful to have you and the rest of the panel join us, because we all bring such unique insights from the varied backgrounds that we all have. So thank you. Selva Sekar, if you could introduce yourself and tell us about your work and all the amazing work that BAPIO has been doing in this space.
Thank you, Rajiv. I'm Selva Sekar. I'm a colorectal surgeon based at the Christie, which is the largest single-site cancer center in UK and in Europe. And I represent this forum as the chair for the Northwest BAPIO. BAPIO has got regional divisions, and we celebrated 25 years of a successful functioning Indian organization in UK last month. It was started initially as an organization to support the mainly doctors. Now it has moved to healthcare professionals as There are not just doctors coming from India. There are a lot more, as a matter of fact, a lot more allied healthcare professionals who come from India now. And the scope of the organization has increased. Now we are involved in education, research. As a matter of fact, a fantastic work has been done recently called the Bridging the Gap paper, which looked at various areas where there are gaps which can be addressed. And it's not just relevant for people coming from India. As a matter of fact, any overseas international medical graduate is the way I would put it. And it is led by our president, Dr. Ramesh Mehta, and chaired by J.S. Bamra. Pandemic, unfortunately, has been a big setback for everyone, as we all are fully aware, but BAPIO has done a fantastic work during this time. As we all know, people from the Black and ethnic minority group were affected disproportionately during the COVID pandemic for various reasons, and that was put to frontline by BAPIO and similar organizations. And we have also been involved in work in India because the pandemic initially affected more the Europe, and then the second wave when India was affected, BAPIO took the front line and also supported in providing equipments, funds, working with various organizations in India and the British High Commission and also the National Health Assembly. And there is still ongoing a lot of collaboration between India and UK through BAPIO, and also we do a similar sort of work through the Christie, which has an international arm, so there is a lot of international collaboration, mainly with India. Thank you.
Thanks so much for sharing all the amazing work that you've been doing, and I think the introductions themselves have already generated so much food for thoughts, and we want this to be a very informal conversation. So please feel free, if you're watching at home or tuning in across the UK, India, or around the world, please do feel free to share your thoughts with our team, and we can help bring them to the discussion. So I think you raised a very valuable point, Salvaseko, around bridging the gap, and I know that there's lots of work being done in this space. I wonder if we can all, share a bit more about the work going on to support Indian and UK graduates. So if we can start with Tista.
Yeah, absolutely. I think one thing that is probably really useful to note is that we've got in a register of 300,000 doctors in the UK, 30,000 qualified in India. That's larger than any geographical region outside of the UK, never mind a country. So, India and our relationship with India is incredibly important. And that means that in terms of work going on, we do a lot of work with networks, diaspora networks, for example, as well as more formal organisations like BAPIO, and that's really to ensure that we maintain but also strengthen relationships. And the work that the Bridging the Gap work that Salvaseko has referred to, that's going to be incredibly important for a number of areas that are, if you will, flagship programs for us going forward. So, for example, our core standards, good medical practice, the work that we're doing for that, Bridging the Gap, is helping to inform. So these links, that's just illustrative of how these links are incredibly important. More broadly, we run induction. I've touched on it briefly, but we run induction for doctors new to the UK. And that induction looks at everything from medico-legal differences to actually welcoming and thanking international colleagues for all they bring. Sometimes I think the focus with international medical graduates, IMGs, can be what support do they need? And of course, support is needed, but that weight of thinking about what support is needed can sometimes be can sometimes forget that actually there's a huge amount of value as well that we also need to focus on to spread learning. So that induction looks at all of that, but also things like culture shock. And that can be everything from, oh my God, I knew it was cold, but I didn't realize it was this cold, to I saw a tweet this morning from Adam Rutherford, the scientist, saying he'd shared a tweet from an American who's saying, every time I leave a lift or an elevator, as he put it, I always say, have a great day. And Adam Rutherford quoted the tweet saying, please don't do this in England. So all of these cultural quirks that people simply can't be familiar with without proper support, that's what one of the things that we're trying to do through induction. And I think once we start talking a little bit more today about collaboration, I've got some thoughts on what we might do there, but hopefully that gives us an overview to start with.
Thank you, Tista. I was wondering if anyone on the panel would like to share their thoughts.
Yeah, just to comment, if that is okay. I think I agree with what Tisha is saying. One of the issues what we the GMC has done is this induction program, which is great because when you speak to trainees coming from India, it is not the knowledge where they lack. Knowledge is the same. When Sheila was mentioning about she's not a medic, it is not that which is an issue at all here. It is the non-medical issues which is the issue where we need to collaborate. Because medicine, there are a set format of teaching, training which has been done over years or decades or even centuries, which is the same throughout the world. There's nothing different. We can't change history. We can't change the practice. But what we can change is the culture. What we are struggling is same as the example what Tisha was mentioning. Have a good day. I spent a year at the Mayo, and I can say that what they use, the terminology is what they use. If I use in UK, it is not acceptable. And we say that the Western world is similar. It is not. It is each country has different ways of communication. What is acceptable? What is not acceptable? When we have trainees coming from India, when they're not bothered about the diagnosis which they can get to. It is how to engage with the allied health professionals. What is an acceptable way of communication with the patient? How do they introduce themselves? It is those sort of things is what is an issue. So it is a non sort of a medical side of things is what the issue is, and that is where I think the work GMC is doing and what Back to You and other organizations are focusing on, which is great, is where we can work together and then find a common theme to support. Because going forward, the issues in healthcare is global. It is no more UK or various countries. We are having this conversation where Amandeep is from India and he is participating it from India now. So what COVID has done is brought us together, and we need to look at solutions which will help things to move forward globally for the better care for our patients. Thank you.
I think there's really valuable points there. I've just left the screen to give more airtime to our esteemed guests, and I think that's a really valuable point there, because even within the UK in training there are different cultures and different systems, and when we move on from job to job, there's always that period where about getting to grips with things, and I think that's where the support is really crucial. But arguably, people coming from overseas then really do need the extra support, because from my personal background, we've hopefully been preparing for this over the 5 years of medical school to work in different settings, and I think it's really valuable that now that the work that you're leading, Sister, with the Welcome to UK Practice workshops, and more broadly, BAPIO have been doing a tremendous amount, particularly last year, to support doctors that were stranded with the cancellation of exams. So working together to support each other, I think, has been really important. A bit of a contentious point, really, I think, is also looking at the support for both health systems. And I know that, of course, lots of people are joining the NHS, and we have a huge shortage of staff. But that's also, some may say, is leading to a brain drain. And I was wondering what everyone's thoughts were on that, and how we can actually work more effectively to support both health systems. I wonder if Dr. Vikram has any thoughts on that at all.
Thank you for raising that point also. And, I was listening to the discussion so far. See, between India and UK, I would say, as one of the speakers was mentioning, world is a small place. And after COVID, it has made us realize that how close we are associated with each other, no matter what part of the world we are living in. And India and UK healthcare systems, they have a lot by which they can help each other, in the sense, like when you see at the NHS, the way in which it has been brought up, the systems are there. There are so many innovations which are happening in UK. Similarly, in India, when you see in last 30-40 years, the way in which healthcare sector has developed across all sectors, demand for good healthcare across sectors, that whether it is government or it is private, because in India, private sector plays a very big and important role also in providing healthcare, that it has also come. So like very recently, when we saw that Oxford AstraZeneca thing, there was a UK innovation which was put at a scale in India and eventually benefit. So there are a lot of complementarities between the two systems. And that is why, and also, English being a common language, that is also good help. I think that is one of the reasons for the Indian healthcare professionals, that UK is a country where they look forward to when they want to go out for training, for experience purposes. And I personally feel in today's world, there is nothing which is like permanent migration. We are living in circular economies. The people move from one country to another country for training, and then they might actually go to a third country and settle. And for many of us who come from India, and here we are talking about healthcare professionals, so all of them are well-informed people about their career, about their responsibility to their family and country and career. So they are well-informed people, and they must have option to take an informed choice about the place where they think that they would get a better training or a better exposure. And many of them I know would eventually actually return to India. So that always goes on. So, but my take in the whole thing is that while complementarities do exist, how seamless can you make it? Why somebody studying in a premier institute in India is still to clarify PLAB, I don't get it. So same issues like those, if you say, the fact is that Indian doctors and, and India has now, I think, over a century-old tradition of, medicine, in modern medicine, I would say. When it comes to our own Ayurveda, it will be running in thousands of years. So we are Indian doctors today are regarded with, the demand is everywhere. So if they don't come to UK, they might tomorrow might migrate to a third or a fourth country, even for a training or for a post-graduate or a residentship, or maybe for jobs. Those things will continue. But if we want to bring that traffic to UK, India, and for for both the countries, and I would say especially for the UK, to ensure that anybody should be welcomed, because given the strain in the system and the kind of we see here in UK, the fact is any well-qualified person who is coming in the should be welcomed, because and his or her journey can be done in that regard. It's good. And as I told you, the strongest link in UK are actually Indian origin health professionals working in UK, because even when they are working in there, I know so much they want to contribute back. So many of them actually visit India. So many of them are actually supporting hospitals. So much of, they have still so much of contact with their peer, and some of them eventually actually go back. One of my friends just went back to establish a hospital in India. So in today's world, I feel, we are actually very closely connected to. Thank you.
I think that's lots of valuable points there, Shashank. And I wonder why we can't all have global health passports, where we can, almost be catapulted in different systems, and COVID, has really shown that, through telemedicine and through, supporting each other. I think we've all learnt a lot from our colleagues internationally around supporting healthcare delivery. When things have been particularly bad in each health system, I think we've gained so much as well through that knowledge exchange. So I for one would really look forward to how we can make those credentials more universal and more global. And I think I wonder, Tess, over the GMC work around the medical licensing assessment now being for all UK and international doctors is a step in that direction. Amandeep, it'd be great to hear your views on the matter.
So, thank you. Actually, what COVID-19 pandemic has asked every one of us that why there was a gap in the health of the world that we need to bridge. That is very important, because we were seeing, as the whole world was seeing that it's a common enemy, and we all were working together to get a cure of COVID-19. So now we have started more of collaboration with the UK and with various other countries. So that is one thing what we have to correct, and we have to not only bridge the gap, but we have to make a new road also, so that the coming students who are really eager to join any institute in the UK, like I'm from AIIMS New Delhi, there are many students preparing for PLAB, and they are doing surgical oncology specialties, and they're preparing PLAB to get into the UK. As sir has said, that why there is a need of that PLAB, that is one thing which is important. And second thing is, as sir has rightly said, that it's not the difference in intellectual, it is the difference in the other things like the medical council registration. And along with that, if I say India being a developing country, effect with the finance is also one thing which is very important, because there are many students who are brilliant, but they are eager to join UK and various places, but they are not having so much of opportunities for that. I, being in a premier institute of India, AIIMS New Delhi, it provides a lot of opportunities to students. A lot of interns students comes from UK and from other countries to India to see the culture of how we are treating the patients in the wards. And one thing which we also learn from them, that like sir has said, that how to deal with the patients, talking, greeting the patients, and this is the culture we want to promote in India. And if we see the patients, we are seeing a lot of tuberculosis, malaria, and various type of dengue patients we are seeing, and they say that this much of, like in a ward, if you see 20-30 dengue patients, and they say that, oh my God, this is how much we haven't seen. So that is one thing which gets improved with and the culture we get to know with each other. That is important, and we want that this relationship should be more and more of easier, so that the health science must develop in the next coming 50 or 100 years to go. Thank you.
Rajiv,
Thanks,
can I just?
Yeah, absolutely.
Okay. Thanks, Dr. Vikram and Amandeep Singh. Basically, I've been in UK for 25 years. You know, when I came in the 1990s, the gap was huge. Whereas I don't think there is any more gap. It is each side. India has got its own strengths. UK has got its own strengths now. So we need to look at how we work in a way that benefits both, not just the healthcare sector, because Dr. Hassan is there to look at the wider picture of India-UK partnership. So what I see is, say, for example, in surgery now, there's only one company which was producing the robot, which was an American company. And recently, in the last 2 to 3 years, there have been 2 more companies who have come in. One is from Cambridge, another one is Medtronic, which is the largest healthcare company in the world. Both the companies did their trials in India. They didn't do the trials in UK. They didn't do the trials in Europe or US because India provides a platform where these trials are being facilitated in a way which the companies find easy to work with. So things have changed in India. There's less of a bureaucratic process, I think. That is the reason why these companies are able to do these trials. And another reason, probably, I may be naive here, because the population is huge. There's a big the clinical resources are there for people to do a trial. Because if you look at the population, here in UK, we're talking about 60 million, whereas there it is 1.3 billion. So if someone wants to do a trial, that is the place to be in. So that is how India has moved forward. Whereas when I look at some of the areas in healthcare, the governance is still an issue, unfortunately, in India. And that is why, to address Dr. Vikram's question about why is someone from a premier institute not getting recognized, when we do a master's program here in Manchester for not just for the Indian sort of subcontinent healthcare professionals, but we do it for medics, for the international medical graduate. But the problem is, when a certificate comes from India, when a medical graduate comes from, it is difficult to know where they have qualified from. I know for certain there are people like qualified, like same as Amandeep Singh, from AIIMS or PGI Chandigarh or JIPMER. They are in a different league. Whereas some of the institutions, they have as soon as you get these trainees coming in, there's a huge difference. And because of this difference is why everyone gets tarnished the same way, that you need to get through this process. And that, how do we address that? I think there is a role for both India to play and for the UK to play. Absolutely, there will be one exam, one assessment where you can make sure that healthcare professionals get through that to get into the system. Because at the end of the day, UK obviously will be protective of its healthcare sector and for its patients, and they want to make sure that they get the best. Whereas India, if we want to prove ourselves, have to make sure that the colleges are of a similar league. So there is work for both sides to be done. It is not like, well, why is UK not doing it? Why is the vaccine passport not agreed? It is because of the inherent issues. And I come from India, as I mentioned, but there are issues there which we need to address, the governance side of things. I'm not saying that everything is fine here. Whereas at the same time, looking back at what India can offer for the UK at the moment in surgeries, the volume of cases, what happens in it is huge. The trainees here, we talk about patients being affected during COVID. The next best example of who has been affected is the surgical trainees. You can watch videos, you can watch YouTube, you can watch webinars. You can be, I'm not downgrading medicine. Please don't mistake me. What I'm saying is you can learn the facts. Whereas surgery, you need to have your hands on. You can go through simulation, but you need to have your practice in patients under supervision. And India has got a huge amount of, when we have meetings between surgical communities in India and UK, we talk about 10 cases, 20 cases, whereas they talk about hundreds and thousands. And that is the level at which the surgery numbers are there in India. And for UK trainees the best place now to go and get trained in surgery, to get your volumes up, is in India. And that is the way India has to promote what they have. Like what Amandeep Singh said, the infectious diseases, it is not seen here anymore because of various reasons, which we all know. Whereas that is a good clinical space for colleagues from here who want to practice in the health, infectious disease or do research or education. That is a place. And another thing is what I work in oncology, so I can say a lot of these trials which we use as treatment have been done in Western population. And I know for certain, speaking to colleagues in India, a lot of them don't work, or the toxicity is very high because of the chemotherapy and things, the dosage needs to be adjusted. So these companies are now moving to India for trials because they see that that is the population which gives the numbers for them to complete the trials within a shorter period rather than waiting through years and years because the numbers are not there. So I think we need to look at opportunities on both sides. And as I agree with Dr. Vikram, it is a circular economy and there's no more brain drain. I think there was a time pre-COVID where we were talking about reverse brain drain. People were going from here to India. Why do we need to have this brain drain or reverse brain drain? We need to make sure that colleagues from here can go on a sabbatical to India. When I used to go to India before the COVID at least 3 to 4 times, and when I go there, I go into hospitals, I see the practice. And when you come back here, when you work in the NHS, you think how privileged we are with the setup and how much facilities we have compared to what happens in India. But at the same time, when I'm in India, I see how much innovation goes on because of the necessity. People innovate, people find ways, in surgery for a hernia mesh, people were using mosquito nets, people were laughing about it. But now we are talking about sustainability, where we want to use equipments again and again, reusable, as long as there is enough evidence to suggest the use and throw things have gone now. We're talking about, so I think there's a lot we can bring together and find best ways to work. And as I've already alluded to, it's no more countries. The world is very small, and we need to work together and then find what is best for healthcare professionals and for the patients. Thanks.
I think that's really powerful reflections there.
Can I come in here just for a second?
Absolutely, and I'm loving the discussions. Actually, it's very free flowing, and I know if we're all okay to stay on for 5 minutes.
Just for 1 second, I will just like to make a point. You see, I think Amandeep is here, and I am also somebody who has passed through Indian medical colleges. Let me tell Dr. Saab that as far as medical colleges in India are concerned, their standard is pretty high, and they are very, very strictly regulated. A college which is giving an MBBS degree in India is, I think, at par with even our average college. Will be much better than many colleges which are saying, which might have a different status. Just because something is located in some corner of India doesn't, and people may not have heard a name of that college, does not mean that, I come from a college, which has a lot of students, with lot of doctors in this country, but there are so many others from where doctors may not have come, because the migration trends also differ. Somebody is studying at AIIMS or somebody is studying in any other capital might be thinking of giving studying in some other city in India may not be, but that does not mean and difference among the students you can see in any class. There would be some guy doing better in surgery and some guy who would be better in endocrinology and some guy who may not be better at anything. So those differences are there, but this I completely disagree that there is such a marked difference between somebody studying at, suppose, Maulana Azad Medical College and somebody studying at in Jabalpur or Kanpur or XYZ, that the gap is so much that these guys can't come and train here, and rather than they need to go an exam. And then these people are registered and they by the Medical Council of India. Their colleges are tightly regulated. So I disagree to that. Secondly, on the vaccination point, it was a technical thing and UK government had to eventually come to it, because our vaccine certifications for Oxford AstraZeneca vaccine, it was the same vaccine administered at both the places. The point was taken strongly by India and was resolved. Third thing you said about the technology, Aman is sitting there. I think you guys must give him 2-3 minutes. Please do explain people how many patients you see every day. the kind of queues you have in AIIMS, you know, if NHS gets that queues even for one day, half of the people will hang their coats and run.
Absolutely.
I just finished my OPD and I've seen 110 patients today only. That is true. And the government is bringing next exam also, NEXT. That will also regularize and bring all students of India on the same platform, whether it is AIIMS, PGI, and everyone is the quality of education and the policies are all created by one board, that is Medical Council of India. So everybody sticks to it, and whether related to research and all, but definitely differences in the infrastructure is what matters. And like if Institute of National Importance, JIPMER, PGI, AIIMS, definitely the difference is only in the infrastructure and not in the intellectual capability of the students. That is what I want to say. Thank you.
Can I come in, Rajiv?
I think this is. I wish we had longer to explore this, and I think obviously, I haven't had much experience in the Union Health system, but I was lucky to do an elective at AIIMS, and I was shocked by the volume of patients that were seen every day in the outpatients department. And I think we've all got so much to learn from each other, from each health system, and it's really good to see that in the UK now, health education in England value. It's not, as you say, it's not a one-way thing; it's a two-way thing. We all have so much to learn from actually entering different settings, learning skills, bringing skills to that setting, and globally allowing care to improve for all of us. Because I know you made very good points around innovation, and often innovation, as we've all seen, doesn't is accentuated in times of crisis and in times of high pressured environments. And I think we've seen that, haven't we? I'm conscious that Shella hasn't shared much, and I wanted to see if we could gain a bit more of an insight into the Manchester-India partnership and your role in the ecosystem, and then we'll have a few more minutes left for further discussion, if that's okay with everyone.
Sure. Thank you very much, Rajiv. Just that, Manchester-India Partnership is a special purpose vehicle created by the Growth Company within the aegis of MIDAS, which is Manchester's Inward Investment Agency, for strengthening the relationship between the Greater Manchester region and India. And so, that's why I am here. And it's not only the commercial diplomacy, but the softer aspects of the relationship, which Tista had mentioned about. It's that common culture which Greater Manchester and India, through the living bridge of more than 50,000 Indian diaspora, so it's basically that links, that comfort level, which we want to leverage on. So having said that, so that's about Manchester-India partnership, but a little bit about the discussion that I was following among my esteemed colleagues on the panel. I think, the patient-doctor ratio and the patient-nurse ratio in India is abysmal, obviously, because the population. So we need more doctors in India. We need more nurses in India, and we need a proper GP system. Rather than people in the remote areas being sent to the expensive multi-speciality tertiary hospitals in the metropolitan cities in India. What I think we can learn from the UK example is about the GP system and introduction of GP courses in the medical colleges in the districts, the state-run medical colleges in the districts in India, which, the quality of medical education, as Dr. Vikram said, is, comparable to any world-class organization. But, it's just that, affordable healthcare, keep the people, where they are and not let them migrate to faraway places for better healthcare. So I think that's my little two-bit on the medical discussion. So just improving the patient-doctor and patient-nurse ratio. I think that is what is something we can help with. Thank you.
Yeah. Thanks, Shella. And I'm just seeing from social media comment come in that actually the similarity in provision of healthcare, because in rural settings in both countries, there is a lower ratio of healthcare providers for patients. So I think that's a shared agenda for both countries there, really, in how we not only recruit from those areas, but ensure that the workforce is there to support the population, because arguably the health needs are actually greater than in other settings. So I'd like to open the discussion to the floor now, to everyone around how we can move forwards together and maybe touch on some of the collaborations that are already ongoing between respective organisations.
So if I may come in, I think one of the really, really important things is ensuring that we meet in this way, that we have fora where we can explore opportunities. And I'm sure that there are things that we're doing that even for organisations that have worked closely together, like GMC and BAPIO, there'll be things that we're doing that we're not across, and therefore opportunities. So one of the things that we now have at the GMC is an international arm. And that international arm, and that it could be, Shella, you and I speak as well about this, because that international arm, we do work such as looking at where there can be an exchange of ideas, whether it be around governance, whether it be around systems, etc. So there could be opportunities there. I'm sure that there are areas where we've got very much shared interests, where we could be a more powerful voice together. So, for example, to pick one area, discrimination. It's not a new thing, but I believe that there is a real critical mass now, and we mustn't lose that focus, that particular focus that has come into sharp relief recently. So there is an opportunity there to collaborate and be a more powerful voice together to make improvements, as well as areas like induction. So yes, those are my immediate thoughts. Talking more and picking those areas where we can be stronger together.
Thank you, Tista. And there's the question come in around how NHS colleagues can help with the transition from India to the UK. And I know, both organisations are doing so much, and equally, it's great to see the Consul General of India. The engagement from, I think has grown so much across all organisations. And I know that's been a real, has often been a barrier around engagement, with people, particularly in the online world that we all live in. And I think social media and making ourselves more accessible, and obviously so grateful to have you all join us for this, to really bring faces to those organisations and share the efforts and the dialogue that goes on to support both health systems. So I'm conscious of time, and I wonder if we can all share a quick closing summary, some key points to take away from today. So if we can begin with Shashank.
Thank you so much. I think keys are, for me, the takeaway as far as India-UK healthcare relationship is concerned, as you know, it's one of the priority items when it's a part of our 2030 agenda. Now, there are 2-3 aspects of it. One is, of course, is the collaboration between the two systems. I think there are a lot of opportunities for that. As Dr. Saab pointed out, clinical trial is one of them, and that is also under consideration. It's already going on. But there are many others. COVID has also opened a very big thing of, this digital health, and which has also led to a lot of digital data being generated, which also then calls for research based on the digital data, which also then leads to the protection of data and what can be shared, how it can be shared, and if it can be shared between the two countries in cross platforms. So there are many things like that. And, we recently had a very successful health conference with over 400 policymakers, doctors, and people from industry. And from health industry point of view, as you know, India-UK FTA is in a very advanced stage of negotiation. And hopefully by the end of the year, we should have some good news in that regard. But that would change the dynamics as far as the the industry part of it is concerned. And the third angle, an important angle, is the human angle, which is basically health professionals, migration of people, whether for training, for work, for anything, I would say, between these two countries. Now, that is something which, as I felt, it has to be touched with the human angle. The person who is coming, as I was saying, there is a lot of, all those who are doctors know that, unlike any other profession, it takes so many years for you just to become a doctor. Forget becoming a senior doctor or a senior thing. You spend so many years in college. So after that, if you want to go to UK or work in India or wherever, the thing should be smoother. And that is the best role which BAPIO, GMC and other organizations can play in doing that. And with that, I would say, as far as India-UK healthcare relationship is concerned, the only way is to go up, and it is going to strengthen in the years to come. Thank you.
Thank you, Shashank. Amandeep.
Yeah, so just to add is that the one thing which I feel is in the research part, because being a student now and being writing and doing research, so one thing which we face difficulty is about how to get our articles published in a reputed journals of UK. And that is one thing which we have to see. One is related to the finance issues, and it should be that the UK, because we have a lot of population and we are Indian doctors are doing great research these days. And even if people from other countries are coming and doing trials on Indian population, the Indian doctors are doing themselves the trials, and some have to limit their publication just because of the cost of publication. That is very important. So this thing should be like the open access journals should be provided to the India, and it should be the research should be promoted, and development of science must be done, because if India is a developing country, and we definitely need that support, and that is restricting some of the people from doing research. That is one thing which is to be, if it can be improved by the journals based in the UK, whether it is BMJ or whether it is others. That is what I want to do. And the second thing is internship is definitely going on from various part from the UK to India. People comes, and that should be promoted, and more often it should be done. And after the COVID era, definitely it will start again and build good relationships between young doctors of the whole world, and we can see a different world in the coming future.
Thank you, Amandeep. Salva Sekar.
Thanks very much. I think this forum has been very useful. I have gained a lot. And what I think is going to be a biggest problem post-COVID is going to be the healthcare professionals' well-being. I think we already see a big problem in UK. There's a lot of sickness which is going on. Some of it is COVID related, more of it is stress related. And I've always felt one of the ways by which you can address that is people moving around, working and having sabbaticals, which we touched upon a bit earlier. If there is a way by which healthcare professionals from here can work in India, if that can be facilitated, and a similar way, what Dr. Vikram Saab has mentioned about people from India coming to UK. There are a lot of UK trained people who are working in India now, and I know for certain they're doing exceptionally good work. And if they can come to UK to work, cover some of the gaps at the same time, they feel that they are in a different system. And similarly, from people from here going back to India to do some work, because it's not easy going back to India and finding the right place as well. It is, it has got its own barriers, same as what we have discussed about UK having its own barriers here. So if we can facilitate that, that'll mean that the workforce in both sides can be kept to a reasonable level to provide high care quality for the patient. Just to touch upon what Dr. Hassan was saying about the infrastructure in India, where in the peripheries, because it is a huge country, where do we need medics to go there? People who have been, I think, I don't think we need medics anymore. We can train people who are non-medics. A similar system is coming here, allied health professionals who are not nurses, who are not medics, who are doing extended roles. You don't, there are people who are passionate about healthcare, but they don't have the qualification, but they want to do something good. We can train people in a certain level of competencies as long as they are being trained, as long as they are assessed, and we can do that. So we don't need medics or we don't need nurses, but we can have healthcare professionals who have been who have developed certain competencies, who can work in the peripheries, refer appropriately, and this is where the digital system is useful, because I know of one of my colleagues who is working in an eye hospital where in Pondicherry, where they do a lot of these periphery clinics, and they're not medics or nurses, they are healthcare professionals who have been trained to take scans, eye scans, and forward it to the center so that people in the center can look at it, and AI and things like that can be used to identify patients who need to be brought to the center. Otherwise, the rest can be treated at periphery. So you provide local care at the local level, specialist care at the specialist level. And I agree with Amandeep saying about research. I think this is where it is important. At the moment, it is Western Western world designed research. Is it the right way? I don't think so. I think there are a lot which the people from the Indian subcontinent, people from the rest of the world can change. It's not just one methodology is the way, but it will take time, and we need to. And we have got various organizations in surgery where we collaborate with Indian organizations. So they're massive organizations, huge amount of clinical materials. But what they ask for is assistance with research, how to get it published, so we work with them, and then it benefits both. So I think there's a huge opportunity to collaborate and work so that it helps the well-being of the healthcare professionals and also the patients. Thank you.
Thank you. And just to share, later on today in the program, we will be hearing from clinical entrepreneurs in the NHS and India who've been creating innovations to support both health systems in digital health, and with a particular emphasis around communication, with Dr. Sandeep Bansal and Dr. Tamsin Holland-Brown, who's leading the way in supporting children with hearing loss. So please do tune into those sessions. And Tista will be on shortly as well to share more around the work the GMC are doing to support international medical graduates. So hopefully Tista will be able to grab a break after this session shortly. But over to you, Tista, for your final words on the roundtable today.
Yeah, so I think my previous comment probably preempted this a little bit in that, and given what everyone else has just been saying now, that's just sort of crystallized and galvanized my thoughts earlier further. I think we need to meet again. I think this has been a really rich, useful conversation, and I've got so many ideas firing in my brain now around what we can do with our international arm, how we can collaborate more on induction, the smoother path element that that Dr. Vikram was talking about. I think there's a lot more that we can do there, and in fact there is a program on at the moment with NHS that I hope will make a huge difference, but we need to make it happen. So I'm not going to say too much more, given timing. My session's due to start imminently, so I think let's leave it at that. My final thought being huge opportunities to collaborate. So let's reconvene and ensure that we can.
Great, thank you. And we will be sharing key points from the session and with everyone and our attendees for a follow-up, because it's been such a rich discussion. Shall, I just wanted to ask if you wanted to add anything from your side.
You mean me?
Yes.
Okay. Yeah, just, a couple of key takeaways that I've got out of this session was, the whole idea of soft skill, which Tista spoke about. That's so important to immerse, that immersion, that cultural immersion is so important, and which works both ways. So I recognize that. Then common recognition of degrees between both the countries. I think that's also one of the key asks in the forthcoming free trade agreement. Thirdly is the growing importance of digital health. That's going to help both countries immensely, and that's one of the key strengths also of Greater Manchester area, digital health. I think all these things will be possible to achieve if we have the right funding availability. I think we haven't touched upon the funding availability at all on this discussion, but I think bilateral funds, and when governments are talking to each other, these things will get faster facilitated if we have a corpus of funds to be able to push this. So these are my closing remarks, and very happy to be here. Thank you for the opportunity.
Thank you. And finally, a big thank you to our esteemed guests for joining us today. It's been a really rich discussion. Really looking forward to the future and how the India and UK can work more closely together to support both health systems. So a big thank you once again. And please do take a break, and we'll be back on screen with Tista, who will be telling us more about how you can thrive in the NHS and all the amazing support available to you from the General Medical Council. Thank you once again.
Thank you so much.
Thank you. Thanks very much.
Thank you.
Thank you very much.
My name is Mark Radford. I'm the Chief Nursing Officer for Health Education England.
I'm Sarah. I'm a neurosurgery trainee, currently working in Cambridge.
I'm Adrian James. I'm the President of the Royal College, and I'm really delighted to be here.
My name's Abby, and I'm the Careers, Information and Quality Lead for the NHS Health Careers team. I hope to be able to get across to you some of the amazing opportunities within the NHS.
We have got podiatrists, occupational therapists, speech and language therapists.
So we're going to talk about good medical practice, we're going to talk about protecting patient safety.
Because of the restrictions, because of remote working, because of a lack of face-to-face contact, because we have to manage patients a different way, we've had to think differently about how we manage this work and how we use technology.
I'm in London, so good to see you. I think we've got Ian here as well, haven't we? Hi, Ian.
Hey guys. We are not the only people who are facing problems, but actually through sharing those problems, we can become the health professionals that are required for the globe and for the NHS in the future.
It's been really interesting hearing all your top tips. I've got my list now. I can pack my bags. I'm going to wear my seatbelt for safety, but I am going to look out the window ahead of me and enjoy the trip.
It's just about us finding the greatness within us and bringing it out and being our best self.
It's been a brilliant day bringing together so many different organisations, healthcare professionals, students from across the UK and beyond.
It's an amazing opportunity to learn about such a huge range of health careers. We hear a lot about medicine and dentistry, but we don't often hear as much about the 350 roles within the NHS, and that's something that as a conference we hope to try and challenge, to get people to think beyond the courses that everyone knows about.
There's something for everyone, and it's from undergraduates for students, all the way up until people who are graduated and are working.
We've got AHPs, we've got aspiring medical students, dental students, nursing students. So everyone's represented here.
It is designed to have something for literally anyone. No matter what you're interested in, we will have a talk that covers it.
This is a brilliant programme that brings together so many different professions within the healthcare community, and it's one that should definitely be on everyone's calendar.
My name is Mark Radford. I'm the Chief Nursing Officer for Health Education England.
I'm Sarah. I'm a neurosurgery trainee, currently working in Cambridge.
I'm Adrian James. I'm the President of the Royal College, and I'm really delighted to be here.
My name's Abby, and I'm the Careers, Information and Quality Lead for the NHS Health Careers team. I hope to be able to get across to you some of the amazing opportunities within the NHS.
We have got podiatrists, occupational therapists, speech and language therapists.
So we're going to talk about good medical practice, we're going to talk about protecting patient safety.
Because of the restrictions, because of remote working, because of the lack of face-to-face contact, because we have to manage patients a different way, we've had to think differently about how we manage this work and how we use technology.
I'm in London, so good to see you. I think we've got Ian here as well, haven't we? Hi, Ian.
Hey guys. We are not the only people who are facing problems, but actually through sharing those problems, we can become the health professionals that are required for the globe and for the NHS in the future.
It's been really interesting hearing all your top tips. I've got my list now. I can pack my bags. I'm going to wear my seatbelt for safety, but I am going to look out the window ahead of me and enjoy the trip.
It's just about us finding the greatness within us and bringing it out and being our best self.
It's been a brilliant day bringing together so many different organisations, healthcare professionals, students from across the UK and beyond.
It's an amazing opportunity to learn about such a huge range of health careers. We hear a lot about medicine and dentistry, but we don't often hear as much about the 350 roles within the NHS, and that's something that as a conference we hope to try and challenge, to get people to think beyond the courses that everyone knows about.
There's something for everyone, and it's from undergraduates for students all the way up until people who are graduated and are working.
We've got AHPs, we've got aspiring medical students, dental students, nursing students. So everyone's represented here.
It is designed to have something for literally anyone. No matter what you're interested in, we will have a talk that covers it.
This is a brilliant programme that brings together so many different professions within the healthcare community, and it's one that should definitely be on everyone's calendar.
My name is Mark Radford. I'm the Chief Nursing Officer for Health Education England.
I'm Sarah. I'm a neurosurgery trainee, currently working in Cambridge.
I'm Adrian James. I'm the President of the Royal College, and I'm really delighted to be here.
My name's Abby, and I'm the Careers, Information and Quality Lead for the NHS Health Careers team. I hope to be able to get across to you some of the amazing opportunities within the NHS.
We have got podiatrists, occupational therapists, speech and language therapists.
So we're going to talk about good medical practice, we're going to talk about protecting patient safety.
Because of the restrictions, because of remote working, because of the lack of face-to-face contact, because we have to manage patients a different way, we've had to think differently about how we manage this work and how we use technology.
I'm in London, so good to see you. I think we've got Ian here as well, haven't we? Hi, Ian.
Hey guys. We are not the only people who are facing.
Welcome back. I hope you've all been able to grab a quick bite to eat, have a drink, or even make use of the networking function. Don't forget to check out the exhibition booths, of course, during the breaks, where the GMC have lots of useful resources amongst other partners. So, without further ado, I'd like to reintroduce Tista. He's got a great session lined up around supporting you to thrive in the NHS. Tista.
Thank you, Raj. Welcome, everyone. Hello. So as you know, I am Tista, and I'm really, really, really pleased to be with you now to explore, welcome to UK practice and how you can thrive in the NHS. I suppose the first thing to say is if you are thinking of joining UK practice, or have recently joined, then a very, very massive welcome to you. It's hugely important that you, as we were talking before at the round table, it's hugely important that you have a smooth experience, and we are utterly grateful. We are very, very reliant in the NHS in the UK on colleagues who qualified internationally. Over 30,000 actually qualified in India. So we're always very grateful to you and always very welcoming of you. So the plan for the rest of the session really is to explore some of the challenges as well as the opportunities, and provide a little bit of a taster session around that induction that I spoke about earlier. But before I do that, I introduced myself very briefly earlier, so just a little bit more thoroughly, I'll give you a little bit of background. So, as I said, I've been in healthcare for a while now, 25 years, and that work is predominantly with survivors of abuse. And over the years, I became really, really interested in how, when systems don't work well together, those survivors can be impacted very negatively. And of course, that applies much more broadly to patients, to service users, but also the professions. So when 10 years or so ago, a colleague and I were asked to set up a support service for colleagues on the ground by the GMC, I was really excited by that opportunity, like being at the vanguard of things. And as I say, it's really important to ensure that that support is there. And it's not something that I'd ever seen a regulator do. But then when I started having set up the service initially and scoping things with people, it became really, really clear that we were thought of predominantly in fitness to practice terms, because one of the very first conferences that I spoke at, I was introduced on the conference podium to the theme of the Imperial March, Darth Vader's theme tune, for those that don't know. And the conference organisers, whilst they were joking, it was really, really clear that they were making that point that you, are seen as being that ivory tower regulator. We are really, really fearful of you. And it was that moment that crystallized for me what fear we're beheld in, that level of fear, but also what we needed to do. And as I learned more about the GMC and all our work, it became really, really clear to me that yes, we are thought of predominantly in fitness to practice terms. I understand why, because it's about livelihoods. It's not just a job being a doctor, is it? But of all our functions that you can see here on this slide, standards, that's the absolute fulcrum of what we do. And it informs everything else, whether we are talking registration, whether we are talking undergrad or postgrad education, and indeed fitness to practice. And I would argue that actually supporting colleagues on the ground to deliver the standards, and I'll come more to that in a few moments, that is in many ways more important for patient safety than work on fitness to practice, because the work on fitness to practice, the really serious stuff, serious issues that we see around fitness to practice apply to such a tiny minority. It's actually 0.025% of the register each year where we see such serious issues that doctors are removed from the register. And therefore, logically, but most importantly, morally, the more that we can do to support colleagues on the ground to deliver complex standards, whether we're talking end-of-life care, whether we are talking safeguarding, whether we're talking raising concerns, it's difficult. So the more that we can do to support colleagues to do that, well, that's the right thing for a regulator to do, and supports you as well as your patients far more. So that's kind of the philosophy behind a lot of our work at the GMC. And as I say, all of this links to that support service that a colleague and I set up a number of years ago, and that is now GMC Outreach. And I'll let you digest that. This is what we do, essentially. So, as it says there, we are there. We're regionally based and nationally based. So wherever you work in the UK, you have got a point of contact. And yes, as it says, we are there on the ground offering consultancy and teaching. But what I think is really, really important is that we are also there to hear what's happening. So if you tell me that one of my team that actually last weekend, I'm a foundation year 2 doctor, and last weekend I had 47 outliers in T&O, in trauma and orthopedics, and this is a recurrent issue. I've raised this before, but nothing's changing. Well, then we can provide support. So we provide the teaching, but also the support on the ground as well to ensure that those standards are embedded. And, you know, there we are, working with students there and working here with internationally qualified colleagues. And much of our work is rooted in our standards, and as I say, I'll come back to that in detail in a few moments. But first of all, over to you, really, and please do just throw any thoughts you've got into the Slido if you're joining on the platform. So what concerns do you have about starting UK practice? So if you're in the platform, you can go onto a tab, and we're launching a poll for you there. So I'm just going to flick screens to see if I can see what you're typing in. Right. So, can we launch that first question, please, on what concerns people have about starting UK practice? Oh, has it? Okay, brilliant. I can't see it on my screen for some reason. I wonder if there's a delay at my end. Okay. Okay. Right, for whatever reason, I can't actually see the questions or comments. Right, okay. All right, so yeah, so culture, absolutely, and yes, we know that there are huge challenges with PLAB at the moment. Okay, so I'm just going to okay, brilliant. All right, yeah, communication, yes, that is something that comes up a lot of the time. All right, so I'm not surprised to see any of that, and Scott, thank you for relaying those back to me. I'm not sure what's happening technologically, but that's really helpful. So you're absolutely right. These are the kinds of things that we hear about. PLAB is a more recent one because of the challenges in the system now. And if you go on our website, there's information around dates that we're putting on and how we're balancing ensuring safety given the pandemic and being able to get people through PLAB. But in terms of starting practice, culture, communication quirks, these are the things that come up all the time. And one of the things that I'm going to share with you now, as it's a list that I'm going to share, and as I do this, can you just type in again into Slido what you think this list represents? Okay, and finally, so any thoughts on what you think that might be?
So some of the answers that have been coming in are NHS trust start orientation.
Yeah, absolutely, and
like so people are saying things like induction program.
Yeah, and you're right. This is a real list. It is the real list that my friend had in terms of her induction. So she qualified in Sudan, and 2 weeks later, this was her induction, and 2 weeks later, she was there thrown onto the wards. So, you know, where is the welcome and thank you for coming to the UK. These are the patient expectations here. This is how, this is what the wider ethical framework and the legal framework, the medico-legal framework, that's how that works here. Where is the culture shock, the communication quirks, as someone commented earlier? Where is all of that? Where's the support? It's really, really concerning that colleagues are being given this as an induction. Yes, these things are important, but all of that wider stuff, that is absolutely necessary. And I'm just going to share some quotes with you from international colleagues who we ran focus groups with. And this penultimate point, these are all poignant, but this penultimate one, I'm just going to give you a bit more detail around that. So this doctor, in his country of qualification, there's one type of catheter, unisex catheter. Here we have male and female catheters. How was he to know? It wasn't part of his induction. He again was thrown onto the wards without a great deal of supervision, and when he was, as it says here, asked to go and get the catheter from the cupboard, he was working on a male ward. The cupboard had both male and female catheters. So that was a catastrophe that was eminently preventable through proper induction. And you know, the doctor in question, it has since been supported, but it is absolutely disgraceful that that support wasn't provided earlier. Now, some places do it really, really well, but we need consistency around this. And some of our research shows the kinds of things that's needed, and it won't surprise you. It's that sort of the practical stuff around visas, living arrangements, but networks, the cultural differences that you've mentioned in the chat, some differences in clinical skills, but it predominantly tends to be the culture and language, as in communication quirks rather than English language ability. So it's these areas that really, really need focus. There are other challenges in UK practice as well, and those are around, for example, discrimination and around well-being more broadly. And we were talking earlier this morning about these issues, and well-being, for example, workload is something that really, really impacts on that. So there are challenges, but there's a lot of work going on to address these. And I remember a number of years ago now, our former chair said that the best way to keep patients safe, well, he often used to say this actually, is to keep doctors safe. And that is very much our philosophy. And there's a huge programme of work, whether it is around well-being, whether it is around fairness, that discrimination piece, reflection, supporting colleagues around raising concerns. There's a lot of work going on, and it's ensuring that you've got access to that. So I just want to talk through some of that support now, so that you have got that available to you and have awareness of it to help you thrive in the NHS. So there are networks, whether we are talking diaspora networks, whether we are talking networks for international colleagues. So the Head Start project is one example where international colleagues started here, IMG started here and thought, hang on a minute, we need more for IMGs. So they set up this great project, and they run webinars and all sorts. So there's resources available that way, but there are also formal resources. I was speaking to a colleague very recently, just this week, who had cause to raise a concern. And she was really worried about speaking up, and she was really worried about detriment to her career. And she really valued our conversation because she hadn't been made aware of resources like Freedom to Speak Up at the organisation that she worked at. And she's since linked in with the Freedom to Speak Up Guardian, who has been able to give her really, really good support. So there are some resources that we really need to be primed of from the start, just in case you do need to use them. So when you find yourself, if you find yourself in that situation, it's not a sudden scramble, or you don't feel like you're alone, because these are resources that often colleagues, wherever you qualify, are going to need to access just from a pastoral basis. And there's loads from the NHS directly as well, wellbeing support resources, etc., and us. So I'll come to talking about our standards and the courses that we have around that in a moment, but there's a lot more. That there are learning materials, case studies, CPD, sort of self-assessments and things that you can do as well. There's a huge amount by way of support. Our ethical hub, for one, it is something that is used very widely. So please do access those. But just to move now onto our standards and speak about that a little bit more. So when I talk about our standards, going back to that jigsaw slide where standards was in the centre, I'm referring to good medical practice. So our ethical guidance, and when I say good medical practice, it isn't just the central document there that I'm referring to, but also everything that flows from it. Okay, so that might be decision making and consent, that might be child protection, confidentiality, etc. Sometimes we hear, and even in undergrad here in the UK, I have heard tutors say, this is really good, but a lot of it's common sense. Colleagues, it's not common sense in a lot of cases. This next slide, which is horrible, I don't expect you to try and read it, that's the point. This is a list of all the pieces of legislation that we distilled to put into just one piece of guidance, in this case confidentiality. And that means that, well, there are 47 pieces of legislation here. So that means that doctors either need to know all 47 pieces of legislation, or at least the relevant bits, or you need to have a familiarity with our confidentiality standards, because what our policy teams do, they look at the wider medical ethical framework, and then they look at the salient bits of law and they put it into a more digestible document for you. And that means that the standards are not merely common sense or just best practice, but they are the benchmark. They're the benchmark for practice. Now, that doesn't mean that you need to know it all verbatim, but you need to know the themes covered therein so that you think, OK, I've got a challenging confidentiality scenario coming up. I know these are covered in the standards, so I know I need to pick it up and just have a look to help give me a safety net, moving to the next image, for my decision making. And that's your safety net, and it's your patient's safety net as well. So that's what we want the standards to be. Yes, they're a benchmark, but we want them to support you. So we want them to be your safety net. And we also want them to be a lever for change. So when you are, I don't know, working in a ward, and I'm thinking a stroke ward that I was working with for a little while, they were telling me that they weren't able to apply our standards around DNA CPR. However, because we were working with them, and of course they had familiarity with our standards because we were there teaching them, they were able to use those standards as a lever to make changes. So they had time and the infrastructure to be able to have the appropriate DNA CPR conversations that are needed, that the system wasn't allowing them to do. So the standards, in addition to being the required benchmark, in addition to being your safety net, are also a lever for change that you can use in that positive way to help ensure and nudge the cultural environments that we need to be able to deliver the standards for our patients. So that's how I'd like everyone to view the standards. And if you are coming to UK practice or have recently come to UK practice, a really good way of getting that grounding is by joining our free course. Welcome to UK practice. It's a free half-day workshop. And it covers everything from the culture shock that we've touched on to the support available, but most comprehensively, out of all of the areas that we cover in that course, we really delve into a number of areas of GMC standards and guidance. There are also other resources that I've touched on, such as self-assessment tools and things like that. But the course is, I would say, absolutely fundamental to starting practice here. And no need to use the poll, given that I'm having a few tech challenges here. But question for you, just have a think. Do you think it works, this course? It really does. So 97% felt it improved their knowledge, but I'm just going to highlight this one. 91% would actually change their practice as a result of attending. And importantly, we've got academically robust evaluation as well. And that shows that not only do people say that, yes, they intend to change their practice, but at follow-up, people have changed their practice. And that's highly unusual, actually, for a one-off medical educational intervention. So it really, really makes a difference. And at the moment, given that this is a half-day workshop and we feel that employers have a responsibility to provide much more support, actually, than just allowing their new colleagues to attend a half-day workshop, we're working with NHS England, with their medical workforce rate equality standards team, to further influence induction and develop something that's more comprehensive. And we are hopeful that NHS more broadly will roll that out, so every employer gives that comprehensive induction, which Welcome to UK Practice is a part of, but it's not the totality of. But that's a watch this space thing. In the meantime, you know that you've got Welcome to UK Practice available to you. So I'm going to provide a little bit of a taster now, and it would and one of the scenarios that we use, just by way of example, is where we look at what you might do in certain examples. You know, if a patient is giving you a gift, for example, would you always, sometimes, never accept it? But the example that I want to use right now, so your girlfriend, Elora, needs her prescription filling. So she is she has asthma and she's due to fly to Frankfurt tomorrow evening. And she's not had time to go to her GP, so she's not had time to get her script filled. So she asks you, can you please fill my prescription just on this occasion, because I've not had time. So can we launch the relevant poll around that and see what you think? Do you think you can always, sometimes, or never fill Elora's prescription in these circumstances? And I'll see if my tech woes are over and I can actually see your answers. And if not, dear, it'd be great if you could let me know what people are typing in.
Yes, absolutely.
Thank you.
Just waiting, we'll give it a couple of seconds just
Yeah,
so a few answers rolling in. So we've got an update. So 100% of the answers currently are in the never option.
Okay. Interesting. So let me bring my slides back up. So in these specific circumstances, you're absolutely right. These specific circumstances, no, you wouldn't prescribe. So so that's brilliant. Now, there are some there are some nuances, I suppose. Now, there could be some assumptions that we might make. There could be a reason where Elara absolutely can't access out of hours GP, pharmacist. So for example, if it wasn't the following evening, but actually she's leaving in a couple of hours, then that might be different. But in these specific circumstances, no, I wouldn't. Now, what the standards actually say is wherever possible, you must not prescribe for those close to you, friends, family, those close to you. And it's a wherever possible because occasionally there will be those circumstances where it is the right thing to do. But one of the things that I've always found useful about those standards is that sometimes there can be an expectation from friends and family, because it can be routine in some countries to prescribe for friends and family. There's a real expectation to continue doing that when you start UK practice. And that's where I find things like the standards really useful, to be able to say, I'm really sorry, Mum, actually, I can't. Things like that. But it's great that you're aware of that. So moving on, I want to share a complex case with you. And I mentioned earlier that that I work in sexual assault referral centres, and whilst I've changed the scenario slightly, the details I'm sharing with you is Talia's case, and she is essentially a composite of many of the patients that we see in these scenarios. So, as it says here, she was diagnosed with HIV 2 years ago, but lost to follow-up. Now she's just re-engaged with sexual health, so she's just re-engaged with GUM services. Her partner is unaware of her HIV diagnosis. And you see that she's actually got a history of violence from her partner, and to be clear, it's the same partner. So you're building a really good rapport with her. And as you try and explore things with her, she makes it clear that she doesn't want to go to the police regarding the abuse. She acknowledges that she is still suffering domestic abuse, domestic violence from her partner, but she doesn't want to explore support. She doesn't want her GP to know about her HIV status, because you see that it's blocked off in her records. And she doesn't want her partner to know about her HIV diagnosis. And when you explain that you can undertake anonymous partner notification, she says, well, no, he'll work it out. I absolutely do not want you to breach my confidentiality. So we'll bring Talia back as a whole person in a few moments, but I just want to look at each question individually first. So if we can launch the relevant poll, please. So she's a competent adult, do we have to disclose information about domestic violence? And I think if I go into the Slido directly, I'll be able to see the answers. I can't on the platform, but
if you wanted to, so I can just wait for them to come through in a little bit and then give you some updates, and then if it changes in a little while, I'll let you know as well.
Okay, great. Yeah, no, that's really helpful. Thank you.
I think just giving everyone a minute to answer, and I think it takes a couple of seconds to sort of refresh and reflect onto the platform.
Okay. So, any thoughts? And focus on the question. Do we have to disclose?
So currently 100% of the answers lie on yes to social care, and 0% think to police, and 0% think no.
Thank you. Interesting. So the answer, if you will, and I'll explain this all, I'll break it down properly, but the answer is no, you don't have to. Okay. So, moving on to the next question. Do you have to disclose her HIV status to her GP? Now, of course, we know that there are contraindications that a GP needs to be aware of in order to treat her properly, and for continuity of care, it's important. But she is worried. So when it comes to the bottom line, whilst you're going to provide her with reassurance that her GP has the same duty of confidentiality, you're going to try and, counsel her to ensure that she does let her GP know. Do you have to? So if we can launch the relevant question, if we haven't already, and see if see what our answers are.
So the question has been launched. So again, guys, just keep continuing to answer. So for now, 100% of the responses lie with no.
Okay. And you would be absolutely right. You don't have to. So just unpicking that one a little bit more. There are challenges, of course, as I just mentioned. So you would try and find a solution, and that solution could be that if she really feels, if she doesn't have the confidence in her GP that he or she is going to maintain a confidentiality, then you could suggest changing GP, because it really is important, of course, that a GP is aware. However, the bottom line is that you can't breach confidentiality, but in most circumstances like this, we are able to reassure the patient or find another solution for them. Okay, so the final element then, just to bring that up, if we can launch this question. So again, of course, you've counselled Talia that her partner needs to know, but she won't tell him about her HIV. She is terrified. You can see that she is absolutely terrified. What's your obligation now? Do you have to breach a confidentiality and arrange partner notification?
So right now, the 100% of the answers lie with yes.
Interesting. Okay. So the answer, looking at the language of the question, must you arrange partner notification? The answer is actually no. So let me explore that with you. When we're looking at disclosing information, confidentiality, there are three things that we need to consider, and the standards, I've taken the key points out of the standards and guidance and put this into a little bit of an algorithm for you, and a lawyer colleague came up with this as a mnemonic clap, which is frankly slightly hilarious when you're talking about sexual health, but we'll go with it. First consideration: have you got consent? In this case, we've not got Talia's consent. Of course, you would explore and provide her with reassurance, but if you've not got consent, that is clearly out of the question. So the next consideration is there a legal requirement? Does the law compel you to share information? And in this instance, so whether we're talking about the domestic abuse, where a number of you thought social services would need to have the information shared with them, or whether we're talking this disclosing partner notification wise, there is no law in statute that says you must share information in these circumstances. There are laws that are relevant, for example, reckless transmission, but that's not a law that applies to you as the doctor to share the information. So that brings your decision down to the public interest test. So as a doctor, you've gone through, okay, I've got a really difficult confidentiality scenario here. I've not got the patient's consent. There isn't a law that proscribes me to share the information. So that means I have to use the public interest test and exercise my professional judgment. And the public interest test is where you balance the benefits to an individual or society versus the harm to the patient, first of all. And that balance, you know, in this scenario, we can see that there might be harm to Talia. That's the harm to Talia there. But we can see that there are benefits to her partner, or indeed wider society, because he may be sleeping around, she may be sleeping around. So based on that, what do we put more weight on? Well, there's one other thing to consider in the public interest test. And that is the public interest test in having a confidential medical service. So, for example, if your sexual health clinic, if your small GP practice, if my sexual assault referral centre gets a reputation for being leaky with confidential information and patients stop presenting, then that is a wider public confidence issue, that public interest in having a confidential medical service. So those are all the things you need to weigh before you make a decision. And that doesn't necessarily, certainly in this scenario, make it suddenly, oh yes, I know what to do. It doesn't suddenly make it clear, but it gives you an idea of the complexity of all of the factors you need to consider. And with anything like this, you can put in all of those factors into, you can balance them all. So every factor can make a difference. Now, Talia, right now, you're building a good rapport with her. You might think that, hang on, we're getting a good relationship. She has represented. So I think that in the next couple of months, I can get her somewhere safe from a safeguarding point of view, and then undertake partner notification. It could be that Talia has children in the home. That changes the balance of the scales completely, doesn't it? It could be, it won't be in this case because she's only just re-engaged, but it could be that she has a zero viral load. Changes the scenario completely. It could be that she got HIV from her partner. You know, there are all kinds of considerations that change the balance, and that's why with things like this, there aren't any definitives. It's down to your professional judgment, but it's not easy. So we also say in the standards, take advice. There are 24-hour medical defence organisation helplines. We've got an ethics helpline that you can write into as well. And experienced colleagues always get a sense check, because in a scenario like this, I know where my biases are, but I appreciate there's no room for my biases. So that's what Welcome to UK Practice. That's what sessions from our outreach advisors do. I'm not going to read through the next paragraph with you, but it's a complex paragraph, and we break that down for you and show you how to interpret our guidance. So this is about the public interest test. So that's it really, and I want to leave you with a final thought as we start to hit the 45-minute mark. So what we asked patients and public, what makes a good doctor? So can you just type in, please, if we launch the next poll, what one word do you think was most commonly said as what makes a good doctor? And hopefully we will start to generate a word cloud in a few moments. Any thoughts? Okay, I can see some words coming in. We've got compassionate, so I can see it now, dear.
Okay, great.
Yeah, compassionate, advocate, professional, problem solver. And there we have it. Someone's put in listener and caring. The most popular word, and we spoke with hundreds of patients, was listens. Okay. And everything that you've said about being professional, about being an advocate, you know, you can see that those are here as well. But the most important thing was listens. So final couple of things to say then. I hope that's given you an overview of how complex some of the standards can be, and how it was only a very quick taster today. Of course, if we were doing the workshop, we would have an opportunity to really discuss these things in the room and address questions. So that's what our workshop does. It looks at those complex areas for you. I hope today has also given you an overview of some of the support resources available. And I'm sharing with you as well, and this link will be made available, the slides will be made available, a beautiful video that a number of IMGs, International Medical Graduates, did for us on things that they wish that they had known when they started UK practice. So please do access that. It's a short video, just under 10 minutes, with some tips from them. And that's shown in our course too. But then finally, please do have those things in mind. My biggest takeaway, of course, is, as you might imagine, please do go to our website and sign up to Welcome to UK Practice, and we can talk more thoroughly about all of the areas there. And that's it from me. Thank you very much for your time, and I hope to see you in person or virtually at a Welcome to UK Practice sometime soon. Thank you very much.
Great. Thank you very much, Testa. As always, you've given us such a valuable presentation, and I hope that everyone learned something from this. I know I sure have, and it was extremely useful. So thank you so much.
Very welcome.
Problems, but actually through sharing those problems we can become the health professionals that are required for the globe and for the NHS in the future.
It's been really interesting hearing all your top tips. I've got my list now. I can pack my bags. I'm going to wear my seatbelt for safety, but I am going to look out the window ahead of me and enjoy the trip.
It's just about us finding the greatness within us and bringing it out and being our best self.
It's been a brilliant day bringing together so many different organisations, healthcare professionals, students from across the UK and beyond.
It's an amazing opportunity to learn about such a huge range of health careers. We hear a lot about medicine and dentistry, but we don't often hear as much about the 350 roles within the NHS, and that's something that as a conference we hope to try and challenge, to get people to think beyond the courses that everyone knows about.
There's something for everyone, and it's from undergraduates for students, all the way up until people who are graduating and are working.
We've got AHPs, we've got aspiring medical students, dental students, nursing students. So everyone's represented here.
Is designed to have something for literally anyone. No matter what you're interested in, we will have a talk that covers it.
This is a brilliant programme that brings together so many different professions within the healthcare community, and it's one that should definitely be on everyone's calendar.
My name is Mark Radford. I'm the Chief Nursing Officer for Health Education England.
I'm Sarah. I'm a neurosurgery trainee, currently working in Cambridge.
I'm Adrian James. I'm the President of the Royal College, and I'm really delighted to be here.
My name's Abby, and I'm the Careers, Information and Quality Lead for the NHS Health Careers team. I hope to be able to get across to you some of the amazing opportunities within the NHS.
We have got podiatrists, occupational therapists, speech and language therapists.
So we're going to talk about good medical practice, we're going to talk about protecting patient safety.
Because of the restrictions, because of remote working, because of the lack of face-to-face contact, because we have to manage patients a different way, we've had to think differently about how we manage this work and how we use technology.
I'm in London, so good to see you. I think we've got Ian here as well, haven't we? Hi, Ian.
Hey guys. We are not the only people who are facing problems, but actually through sharing those problems we can become the health professionals that are required for the globe and for the NHS in the future.
It's been really interesting hearing all your top tips. I've got my list now. I can pack my bags. I'm going to wear my seatbelt for safety, but I am going to look out the window ahead of me and enjoy the trip.
It's just about us finding the greatness within us and bringing it out and being our best self.
been a brilliant day bringing together so many different organisations, healthcare professionals, students from across the UK and beyond.
It's an amazing opportunity to learn about such a huge range of health careers. We hear a lot about like medicine and dentistry, but we don't often hear as much about the 350 roles within the NHS, and that's something that as a conference we hope to try and challenge, to get people to think beyond the courses that everyone knows about.
There's something for everyone, and it's from like undergraduates for students, all the way up until people who are graduated and are working.
We've got AHPs, we've got aspiring medical students, dental students, nursing students. So everyone's represented here.
Is designed to have something for literally anyone. No matter what you're interested in, we will have a talk that covers it.
This is a brilliant programme that brings together so many different professions within the healthcare community, and it's one that should definitely be on everyone's calendar.
My name is Mark Radford. I'm the Chief Nursing Officer for Health Education England.
I'm Sarah. I'm a neurosurgery trainee, currently working in Cambridge.
I'm Adrian James. I'm the President of the Royal College, and I'm really delighted to be here.
My name's Abby, and I'm the Careers, Information and Quality Lead for the NHS Health Careers team. I hope to be able to get across to you some of the amazing opportunities within the NHS.
We have got podiatrists, occupational therapists, speech and language therapists.
So we're going to talk about good medical practice, we're going to talk about protecting patient safety.
Because of the restrictions, because of remote working, because of the lack of face-to-face contact, because we have to manage patients a different way, we've had to think differently about how we manage this work and how we use technology.
I'm in London, so good to see you. I think we've got Ian here as well, haven't we? Hi, Ian.
Hey guys.
We are not the only people who are facing problems, but actually through sharing those problems, we can become the health professionals that are required for the globe and for the NHS in the future.
Health Careers Live India. And now for the session you've all been waiting for, digital health, clinical entrepreneurship and innovation. Today we're joined by two inspirational entrepreneurs, both clinicians by background, who've found problems and really gone all the way to solve them and improve healthcare for the better. First up, we have Dr. Sandeep Bansal, founder of Medic Bleep and CareBite in India. And following Sandeep, we'll have Thompson Holland Brown, a paediatrician based in Cambridgeshire, who's been leading the way against supporting hearing loss in children and is also part of the NHS Clinical Entrepreneur Programme. So, Sandeep, how's it going?
Yeah, good. Thank you, Rajiv. Thanks for having me.
It's great to have you here. And just to give you a bit of a brief around what we've been discussing today, we've had some really stimulating conversations this morning around digital health and innovation, particularly across UK and India on the Roundtable. And I know that you've achieved a tremendous amount. So I was wondering if you'd be able to give us a bit more of an insight into yourself and the work you've been doing. Over to you.
Yeah, absolutely. Thanks, Rajiv. And thank you all for joining the session on a Saturday and giving up your Saturday afternoons in India and Saturday mornings in the UK. So I've got a slightly different, unique perspective, I guess, just because of my journey. So what I'll do is go through a little bit of my journey, talk to you about my journey into entrepreneurship and the challenges that I see in the world of healthcare going forward for future generations. So how I'm slightly different is I'm born and brought up in the UK, but I actually ended up going to India to do my medical degree. So I graduated in Manipal, so in the southern region. Usually it happens the other way around, where students come across from India to UK medical schools. However, I didn't actually get into the medical school that I wanted, which was Cambridge. And I guess that was my very first understanding of what it is like to be an entrepreneur, because failure is just so common. I graduated from Manipal, and then after Manipal, because that was a private medical school and private medical system, I kind of wanted to understand what's it like to work in a government hospital, government system in India, and compare it a bit more to the NHS, comparing it like for like and apples to apples, I guess. So I went and worked in a government hospital, a very busy hospital in Delhi called Hindu Hospital. That was a really, really eye-opening experience for me. You know, as a junior doctor in the NHS, on a given day, my patient list would be 8 to maybe 15, 16 strong. But in the government hospital, usually I was looking after a 60-bed ward, but typically there were over 80 to 100 patients on those beds, doubling up. And it made me appreciate the NHS a whole lot more and what we have in the UK, for sure. I came back across into the UK at that point and worked 5 years clinically. In that time, I took a gap year to do a master's in pediatrics from Imperial as well. I also, my family background is that we run nursing homes. So nursing homes, just for those from India here, nursing homes in the UK are very different to those in India. They're social care settings, they're for the elderly. So old age homes basically is probably what you know them as. And I scaled that business from 200 beds to 420 beds and grew it to about £15 million in revenue. Now, at that point in life, from my naive eyes, I thought that social care system was very connected to the NHS. However, having gone through that process, I realized it's far from the truth. 2012, I came back into the NHS and was doing GP training in Oxford, when I realized that actually technologies are going to be a key enabler to moving healthcare systems forward for the future generations and to make sure that their NHS is sustainable. One of the key challenges that I saw was around communication, all the way through social care, right the way through primary, secondary care, inter-team communication, which is very fragmented. You know, you'd often get patients coming to hospital or being in an ambulance and having to repeat their stories time and time again. And, you know, if you're a patient and you're suffering, that's the last thing that you really want to be doing, you know. And I thought that us clinicians, we should have the right tools to actually not let that happen from the patient perspective and journey. And I did a survey of 2,000 doctors, and 75% in 2014 December admitted to using WhatsApp to share patient data. Now, of course, that's not really compliant with healthcare regulations here in the UK. And I know these sort of regulations are also coming out in India now as well. But that wasn't the problem. The problem is that actually clearly the older ways of communication were not optimal for patient care, for delivering patient care. So that's when I started out on my journey of creating a instant messaging solution, basically called MedicBleep, which is much like WhatsApp, but for inter-team communication, and the conversations around patients go directly into the patient record. What we showed is that we save each nurse 21 minutes per shift and 48 minutes per shift for every doctor. Now, if you extrapolate that out across the NHS, That's the equivalent time saving for 11,000 nurses. Now, I don't know how aware you are, but we're 40,000 nurses short at the moment in the NHS. So just giving such simple tools and solutions could save up to 25% of the workforce's, the gap in the workforce time. However, it's not as simple as that. Implementing change in the system has been a hard journey. And along the entrepreneurial journey, I've realised some of the bureaucratic hurdles that exist in the NHS, some of the challenges with regards to change management, and just getting frontline time. So if the NHS is 95% capacity, especially during COVID, that literally means that every hour and 15 minutes after a patient is discharged, that bed is being filled again. Now, where in this journey does a doctor or a nurse actually have time to engage with change? They're just fighting fires. So these are some of the big challenges that we need to try to work upon as a system. With MedicBleep, we partnered with British Telecom and Apple and Samsung to remove those pages. But during the pandemic, I think it became really apparent to the global to the whole globe and to all the world and individuals that what we need to do is actually move a paradigm shift in healthcare. It's not just about fighting the fires, it's actually about preventing disease rather than trying to put ourselves in a position where we need to cure. So just some statistics which really stick out to me. 2 in 7 of us live with non-communicable disease at any time. Now, most of these are preventable. A lot of you are clinicians on this call, so we can prevent them from lifestyle, nutrition, and good habits. India's instance of diabetes is occurring 10 years prior to that of the Western world, at an average age of 45 compared to 55 in Western nations. The economic impact of these non-communicable diseases in India is estimated to be $4.6 trillion between 2012 and 2030. Now, let me put that into context. You're all aware of the 21-day lockdown that happened in India at the latter part of last year, I think. Now, this is equivalent to 2 national 21-day lockdowns in India every single year from an economic perspective. I also read a stat from the WHO in which 55 million people in India go into poverty every single year due to not being able to pay for their healthcare bills. I was astounded, because obviously in the NHS, we're very fortunate in that we don't need to worry about our healthcare bills and paying for healthcare, unless, of course, we want to and we want to get private care. But at point of care, if there's an emergency, we don't need to worry. That got me thinking a little bit deeper about insurance in India. And only 15% of India, other than those covered by Ayushman Bharat, are actually insured or have any sort of health insurance, which means 90% of India's healthcare spend is out of pocket. Now, workforce challenges also exist, and they exist globally. 3.3 million healthcare workers shortage is going to happen in India by 2030, unless we look to move healthcare and the way we deliver it, again, in paradigms. There's an over-diagnostic and over-prescribing challenge that exists. There's a study done in Madhya Pradesh which showed that 10% of all drugs prescribed and diagnostics done were overprescribed and overdone. Now, that statistic goes up to 50% when you're looking at those individuals over 65. So with all of these sort of challenges, I thought about starting CareBite, which is about to go live in Delhi and Gurgaon region in the next 20 days, focused on preventative healthcare and primary care. Another problem that I saw in India is, as a junior doctor, I could have been a GP immediately after graduating in India, whereas in the UK or in the US or Australia, any developed nation, I had to train for another 5 years to become a GP. So we're trying to bring that level of robustness and working with the MRCGP and other sort of organizations to bring that level of robustness into India. Now, it's about how can you incentivize people and shift care downstream so that they actually look after their own healthcare when it comes to it. That's the holy grail, right? They shouldn't really be needing to come to a doctor in the first place, because if that's the case, then surely at some systemic level we fail them. That's how I see it. And so CareBite, what we're trying to do is incentivize them by giving rewards. So if they're sticking to their healthcare habits and achieving their own goals for their own health, which could be very individual, of course, they get rewards, which then they can redeem at retail stores like Amazon or Big Bazaar or Nike or Starbucks or wherever they so please. So we're trying to gamify and give them some of that instant gratification, which we're so used to. Of course, healthcare and changing health takes a lot longer, so you don't see those instant gratifications. So we're trying to build in a gamification model which can help with that. But these challenges exist globally. These aren't just unique to India. Of course, the NHS is trying to do a lot more when it comes to public health as well. But these are some of the challenges that I've seen as a doctor, as a patient, as someone who's run services before, and these are some of the challenges that I'm trying to tackle when it comes to India. Thank you. Rajiv, over to you, I guess.
Thanks, Sandeep. It was a really powerful 10 to 15 minutes there. I know lots of people have expressed interest to hear more about the work you're doing. I know that you're short on time today. I was just wondering, how you'd recommend people get in touch with you. Are you happy for us to share your details or connect with you on social media?
Yeah, absolutely. My Twitter accounts or my email address. Happy for that to be shared, Rajiv. And I don't know if there's any questions right now that I can help tackle, but yeah, happy for people to get in touch.
Yeah, the team have selected one question, and that is, what's your top tip for a clinician who, has an idea, wants to make it happen? What would you say? What are the starting steps for them almost?
Yeah, so I think the key starting step is you as an individual will need a team around you, right? So it's all about the team, and without a team, without the right people who believe in what you're trying to achieve and the problem that you're trying to solve, it can't be solved. I've got a great team that I formulated over the last year trying to tackle this problem in India, and it's taken me a year to put together a team of 15 people, right, who believe in the same vision. So take that time out to find the right people who believe in the vision, who are the right people to actually tackle that problem with you.
Okay, great. Couldn't agree more. And thanks so much for your time this morning. We're really looking forward to all the amazing stuff and the creativity that you're bringing to all the projects that you're involved with to improve healthcare. Thanks again, Sandeep.
Thanks, Rajiv. Thank you. Thanks. Have a good day. Bye.
So now, next up, we have Dr. Tamsin Holland-Brown. Tamsin has joined us with a few hats, and one of those hats is as part of the leadership team with the NHS Clinical Entrepreneur Programme, which she'll be sharing more about the programme with us when she comes on. She's also an innovator and has been leading some really, really impactful work to support children. Without further ado, Tamsin, can you hear me? I think we're just getting things ready, Tamsin's got some very helpful slides to share.
Yeah, I can. I'll try and share them myself. It was just thank you so much for inviting me along today. Delighted to be here. My name is Tamsin Holland-Brown, and I work as a paediatrician in Cambridge. But I also have been on this innovation journey, which I didn't choose, it kind of chose me, and it's led to many more opportunities as I've grown within my career, which has been amazing. I shall attempt to share my slides, and just to explain where I've got to. And yeah, are you able to see that, Rajiv? Oh, lovely, thank you. What I was able to do working as a paediatrician, I had developed a special interest in children who had a hearing loss. And what I was able to see was that the most common type of hearing loss, which is known as glue ear, but medical community tend to call it OME for otitis media with effusion, but it's what we all know. So even as adults, we will have had a terrible cough or a terrible cold, and our ears will have got really blocked up while we were in the middle of that. And you can't hear very well, but it kind of clears after a few days, and then you feel so much better. But it's okay as adults for us to get that condition, because we already have learnt our speech and language. We're not learning many new words. Even if we lose 50% of what another person is saying, our brains can pretty much fill in the gaps. And also if we get very blocked up ears after a cough, cold or ear infection, it tends to drain really quickly. And I was watching this happen in children, and it happens to a lot of children. So 80% of children will have this at least once. And when we do hearing screens on children who are starting school and have a hearing screen in many countries, we're able to see that it affects at least 1 in 10 children. So I see this all of the time, and I was starting to worry about this condition, because for children, their anatomy is so small that when their ears get blocked, it tends to last much longer, weeks to months. And of course, they're still learning new words, and they're still learning about communication, how to socially communicate, they're developing listening skills about who to listen to, and they're learning how to process auditory information. And so what I was seeing was children who had glue ear, some of them trickling through to my general paediatric clinics with questions like, has this child got a speech and language problem or condition? Has this child got a learning difficulty or disability? Has this child got a social communication problem, or even Asperger's autism? Or have they got an attention deficit? So ADHD or attention deficit hyperactivity disorder. So some of these children, I'd be looking back through their medical records and realizing that they had this condition where their ears were blocked and they couldn't hear well for quite a lot of time. And it started worrying me that for some of these children, they were falling behind and not able to catch up. And of course, what we do for children with glue ear is that we wait. And as medical professionals all across the globe know that it's worth waiting to see if it gets better. And so there's a bit of time where clinicians will say, yes, you can't hear very well, your ears are a bit blocked. Let's see how you go for a few months and see if it clears on its own. The problem is that if people do this for a long period of time, that if this adds up to 6 to 12 months of a child's life, it's a big part of their life, and it's at a critical time in their development of speech and language and listening. So what happens in the UK particularly, that's where some of this data was from, is that if children are persistently deaf from this condition, then we do offer an operation called a grommet operation. In America, it's called a tympanostomy tube or T-tube operation, where the surgeon will cut a little, the child will be asleep under anaesthetic, the surgeon will cut a little hole in the eardrum, drain out the fluid and place a tiny little tube across the eardrum to keep that aerated and let the sound transfer. And those are done. So if we looked up, our first study was to look at how long does it take a child to get one of these operations. And actually, if everyone's working pretty fast, they're waiting, they're doing repeat hearing tests, the ear, nose and throat surgeon is seeing them, they're put on a grommet operation waiting list, that whole thing takes about 12 months however fast everybody's working. And so that's a worry, because a year at a critical time in a child's development means that they might be falling behind. Now, you could put hearing aids on these children, behind the ear hearing aids that we all know about, but the problem is that the fluid inside the middle ear tends to go up and down depending on whether the child gets another cough or cold. So the hearing aids don't work brilliantly, or they need lots of appointments to have the hearing aids checked that they're at the right hearing level, because it's very easy to get it too loud or too quiet. So one device that works really well that I wanted to think about for my patients was that we used one of these devices, and it's called a bone conduction hearing aid, and it's got a little transducer on the side which takes sound as a vibration and sends it across the bones of the skull directly to the inner hearing, which is the cochlea, and it just misses out the eardrum, which is where that's all glued up with fluid. So it just bypasses the problem area and sends the sound straight to the inner hearing, which is not affected by this condition. And I was desperate to use these in big studies to show that we should be supporting children's hearing in this way. But the problem was that these cost £3,000 each, and whilst they are very good devices, I was told if I did the study, how could the National Health Service provide this for almost 80% of children? How could parents afford this on a regular basis? And actually, if you wait long enough, some of this kind of clears up on its own. So I was discouraged from doing that. And this is what sent me on this journey to try to find something that would be affordable and easy to access and support children's hearing early. And so initially, I actually tried to make my own bone conduction. It wasn't terribly good, but it did sort of work. It had lots of leads around it, which meant that it would have been hopeless for a child because it would have strangled them at some point. So I ended up finding at the same time there were these lovely headsets arriving on the market for cyclists. And the reason that cyclists were using them is that they were popping them on like this, and that they were the headsets were not covering their ear canals, but they were able to have their trainer on their phone, which connected to their headset, and they still had their ears open to be able to hear traffic noises and not get run over. So I looked at the best quality of these headphones and thought possibly we could use these for children with this condition, glue ear, in two ways. The child could either wear the headset and we could pair it to a microphone so that the child could hear the teacher really well over background noise, or the child could hear the parent if the parent was wearing it, or the child could hear the speech and language therapist if they were wearing it. And that child could do well and get some speech and language enrichment. But also, instead of the microphone, the child could wear the headset and we could simply pair it to a phone, and the phone could have on it an app which would give which could give speech and language therapy, which could give auditory processing skills and listening skills. And we could make sure that children didn't fall behind while they had this condition. And so I started this kind of journey of research initially very quietly on a Sunday, didn't really dare tell anyone because I was concerned that it might not show good results, but we were really lucky with what the results showed. So the very first research study there was just on the headsets. Do they work? Can children hear with them? And we were able to see that actually, on average, children can hear about 16 decibels better when they're listening to speech. And grommets give about 12 decibels improvement when you do a grommet operation. And in fact, the grommet operation, the little grommet tends to fall out after about somewhere between 6 months and 18 months. And so actually you stop getting benefit from it then. So we were able to show that it's equivalent. The next study I did was I built the app, which had the speech and language therapy that can be uploaded, that has speech and language enrichment activities and listening skill activities. And I just looked at that app with families. Could children use the app? Did they like it? What should we have on it? And in fact, one thing that parents wanted was a hearing screen that they could do at home between appointments. So we added that onto the app, and we tested the app, and we were able to show that the hearing screen was good enough for home use. The third study is actually, we're still waiting to see if it's published, but it was actually looking to see if it would help children with a condition called auditory processing difficulties, which I can come back to later. But the last study I did was last year, and suddenly what we were able to see last year was that in March 2020, as we all know, COVID arrived for us in the UK, and then within a couple of months, grommet operations were taken off. They were unable to be prioritised, and neither were children's hearing services. And so what we were able to do was simply take the headset, the microphone, and details about the app, pop it in an envelope, and see if we could remotely monitor. This is me remotely following up a little guy here whose family have consented to let me use the photograph. And it was a really interesting study because it was the first time that there was nothing available for these children, and we were able to completely support them remotely. And we found out lots of interesting things which are here, which is that these children actually, before the pandemic, end up accessing lots of different health services because they can't hear very well, and so they end up accessing speech and language therapists. They end up seeing paediatricians. They sometimes end up seeing things like occupational therapy services in order to try and cope with sensory loss, but actually their problem is that they can't hear. And so we were able to show that parents can pair up by Bluetooth a headset to either a microphone or an app, and we were able to see that parents found this an acceptable management strategy. And we were very lucky when we did when we surveyed parents that the little blue lines are where the child just had glue ear, and the orange lines is when they were wearing the headset. And it's not rocket science to know that when you have glue ear, the parents describe their hearing as below normal. The child was often mishearing words. The child was often mispronouncing words, had difficulty hearing in a group of people, and had difficulty concentrating. And often their speech was behind. But when we put the headset on, even for in the first 3 weeks, whilst wearing the headset, the children were responding. Their hearing was more normal. They weren't mishearing. It was easier to hear within a group. And in a few cases, their speech was starting to improve at that point. And actually, the interesting thing is that some parents as hospital services returned to normal, chose to stick with the headsets rather than have a full operation. And what we learned from that, and you're always learning, is that one thing that we needed to add to the app was a care plan, because we had completely empowered the families and the children to manage their own condition remotely. But what we hadn't done was make sure that the teachers, the parents could communicate what was happening with the teachers. And we realized that this was a huge thing that I hadn't thought about. And so we ended up making a care plan and uploading it quickly onto the app during the pandemic. And the idea is that we can now treat children with glue ear much earlier in the pathway. We can provide them with hearing much earlier so that we can prevent them from falling behind. And it's been exciting in other countries where people don't have access to ear, nose and throat surgeons, or it's expensive to access hearing aids or grommet operations. We've had some lovely collaboration with hospitals abroad, where in for example the Global South, and due to this wonderful collaboration with the Raspberry Pi Foundation, the National Deaf Children's Society, professor in charge of global health, that we're able to start thinking about how we can get these headsets to be affordable and to people who need them most. So at the moment, with the headset that is just coming out now, is together with a microphone, and the app is free. It will cost about £50, which is a whole lot better than the £3,000 that we had initially. I've been incredibly lucky to have won some awards Of course, it's been a hugely hard journey, actually. And for every 1 page of awards, there's been 10 pages of sitting on the stairs at 2 o'clock in the morning, wondering how we can carry on doing it. But delighted to be contacted by anyone who might be interested, and feel so privileged to have spoken to you all today. Thank you so much. Does that work?
Wow, what a journey, Tamsin. Thank you so much for sharing that. It's phenomenal what you've achieved and the impact you're making. I was wondering if you could tell us a bit more about how others can, take a leaf out of your book and almost continue a journey that so many of us are doing in the Entrepreneur Programme to improve healthcare. Would you mind telling us a bit more about how people can get involved and the opportunities to innovate and improve health through the CEP?
I think the landscape is becoming really rich in this area now, thank goodness. And so I felt like it was difficult, but for every person that's innovating and sort of changing the conversation within their NHS trust, it's quite right that everybody's so busy that they're not doing the preventative work and that we are doing the firefighting. And it's hard to make that change, but for every person that makes a little bit of a change, it changes the conversation locally about and empowers other people. And it also, I think for some people, and I was guilty of this, I thought it was without seeing other people do it, then you feel like it's hard to do that first step, that maybe people will think that, can you stop doing this? Can you just concentrate on seeing the patients? And I think that there is some empowerment from seeing other people do it, but then you get that additional help from platforms such as the Clinical Entrepreneur Programme, which are trying to keep NHS doctors within the NHS, but allow them time to innovate and give them access to professionals and a teaching programme to help them build their innovation and to know what to access next. And I think that those help give validity to people. And of course, that programme, which started quite small a few years ago, is now enormously growing and also starting to be adopted in other countries. So the collaboration between other countries has been huge and hugely necessary, because we don't want to keep reinventing the wheel. We don't want people to start trying to do exactly the same thing. We've got to be generous with our innovations, and we've got this wonderful connection with wonderful events such as this, where you can connect people, and we should have much more of this going on. And I do congratulate this platform for doing this.
I think I think the key word, as you say, is collaboration, and I think there's so much opportunity there, isn't there? And that we've received quite a few questions, and I just, if you've got time, ask you the same question that we've asked Sandeep earlier, because like you said, taking that first step, I think as clinicians, I think there's almost a degree of institutionalization, isn't there, in terms of boundaries, what I can or can't do, rocking the boat. What would you say, if someone now in the audience, and what would you recommend, that they should do if they're passionate about doing something different and taking an innovation or an idea forward? What should be their first steps?
There's in a lot of NHS trusts, there's often now just starting to emerge innovation champions, and if you've got one of those in anywhere that you work, that's great, or anyone who has done something similar. And there often is someone who can help you with starting something. And having those conversations is terribly important. And I think also I hadn't involved the management team. And that feels really big to say, because at the time when you're starting, you feel like you've got this idea, but it might not work. And that's part of innovation. You're risking things, and you might fail. And so I think that don't worry too much about failing. I worried a lot. I was almost too embarrassed to tell anyone that I'd come up with these headsets, and I chose 1 or 2 people very carefully. And one of them was just about to retire, so I thought that if I damaged everything, my reputation and my completely, then it wouldn't be maybe the end of the world. And someone else didn't actually work directly with me, so I was that nervous at the beginning that someone might think that it was silly to think about doing it in a very affordable way like this. And I think that looking back, I wish I'd had a little bit more confidence. And I also didn't see myself as a clinical entrepreneur. I saw a poster which talked about for clinical entrepreneurs who would like to learn a little bit more about getting an innovation out there. And I saw and I thought, oh, I wish I was a clinical entrepreneur, because all of that looks like I could really do with learning about it. And I think that I just hadn't seen myself in it. And I think that's why we have to see representation across the board, from women, from mothers, from everyone, and multicultural too. So I think that it's just important that you can see yourself represented as a clinical entrepreneur. And I hope that the global clinical entrepreneur in the UK is beginning to do that. Thank you so much, Rajiv, for this opportunity. I know you have to move on now, and thank you for allowing me to speak. And I would be delighted to connect with anyone who would be interested to make sure that about either clinical entrepreneur work, or if anyone's interested in the work that I'm doing, then delighted to speak further. And thank you again.
Thanks so much, Tamsin. I couldn't agree more. And there's so much great work happening out there, as you've so helpfully highlighted. I think it's great to see the audience that we have here today, dedicated to patient care. And I think this session with Sandeep and yourself has just highlighted the opportunities that exist for frontline clinicians to innovate, take ideas forward, working with patients and a wide group of stakeholders to improve health. Now, we've had such a great day, touching on so many topics, from digital health, innovation, entrepreneurship, to working in the NHS and the support available to you with Tista Chakravarty-Gannon from the General Medical Council, and our powerful insights that we gained from the UK-India Roundtable earlier in the morning. We want the conversation to keep going. We'd like you to share your thoughts using the hashtag HealthCareersLive. We'll be sharing insights and key points to take away following this event. Now we've got a dedicated space for you to network with attendees, speakers and organisations. If you're on the platform, do click on the networking tab that appears on the left side of the screen. This will match you with another audience member, and you can carry on those conversations around collaboration and innovation. Don't forget to check out our website, where we'll be sharing recordings of the sessions, and you can find out a bit more about the work we're doing in this space. I think now more than ever, we know that collaboration and connecting across boundaries, across countries and systems is so important. And I'm really, really grateful to all of you that have taken your time out today to be part of that journey and ultimately improve the health systems across the UK and India and the world at large. So thank you so much again for your participation, and really looking forward to meeting you again very soon. enjoy the rest of your Saturdays. All the best from the Health Careers Live team here, and once again, a big thank you to our partners, Health Education England, the General Medical Council, and all the organisations and speakers that have made today possible. Thank you.
My name is Mark Radford. I'm the Chief Nursing Officer for Health Education England.
I'm Sarah. I'm a neurosurgery trainee currently working in Cambridge.
I'm Adrian James. I'm the President of the Royal College, and I'm really delighted to be here.
My name's Abby, and I'm the Careers, Information and Quality Lead for the NHS Health Careers team. I hope to be able to get across to you some of the amazing opportunities within the NHS.
We have got podiatrists, occupational therapists, speech and language therapists.
So we're going to talk about good medical practice, we're going to talk about protecting patient safety.
Because of the restrictions, because of remote working, because of the lack of face-to-face contact, because we have to manage patients a different way, we've had to think differently about how we manage this work and how we use technology.
I'm in London, so good to see you. I think we've got Ian here as well, haven't we? Hi, Ian.
Hey guys. We are not the only people who are facing problems, but actually through sharing those problems, we can become the health professionals that are required for the globe and for the NHS in the future.
It's been really interesting hearing all your top tips. I've got my list now. I can pack my bags. I'm going to wear my seatbelt for safety, but I am going to look out the window ahead of me and enjoy the trip.
It's just about us finding the greatness within us and bringing it out and being our best self.
It's been a brilliant day bringing together so many different organisations, healthcare professionals, students from across the UK and beyond.
It's an amazing opportunity to learn about such a huge range of health careers. We hear a lot about medicine and dentistry, but we don't often hear as much about the 350 roles within the NHS, and that's something that as a conference we hope to try and challenge, to get people to think beyond the courses that everyone knows about.
There's something for everyone, and it's from undergraduates for students, all the way up until people who are graduating and are working.
We've got AHPs, we've got aspiring medical students, dental students, nursing students, so everyone's represented here.
Is designed to have something for literally anyone. No matter what you're interested in, we will have a talk that covers it.
This is a brilliant programme that brings together so many different professions within the healthcare community, and it's one that should definitely be on everyone's calendar.
My name is Mark Radford. I'm the Chief Nursing Officer for Health Education England.
I'm Sarah. I'm a neurosurgery trainee currently working in Cambridge.
I'm Adrian James. I'm the President of the Royal College, and I'm really delighted to be here.
My name's Abby, and I'm the Careers, Information and Quality Lead for the NHS Health Careers team. I hope to be able to get across to you some of the amazing opportunities within the NHS.
We have got podiatrists, occupational therapist, speech and language therapist.
So we're going to talk about good medical practice, we're going to talk about protecting patient safety.
Because of the restrictions, because of remote working, because of the lack of face-to-face contact, because we have to manage patients a different way, we've had to think differently about how we manage this work and how we use technology.
I'm in London, so good to see you. I think we've got Ian here as well, haven't we? Hi, Ian.
Hey guys. We are not the only people who are facing problems, but actually through sharing those problems, we can become the health professionals that are required for the globe and for the NHS in the future.